Good morning, sir.
Good morning, good morning. Shall we start?
Yes, sir, you can start.
Okay. So good evening to all of you. We'll, as usual, we start with the short case first. Is my screen visible?
Yes.
Yeah, okay. So we'll start with the story of a 56-year-old man. He came with history of dizziness and imbalance while walking for the last 3 months. There is no true vertigo. History of recurrent falls backwards for the last 1 month. It's a video of the page. It's a short case. Examination, no.
ഇവിടെ മുകളിൽ താഴെ മുകളിലോട്ട് നോക്ക്, പെട്ടെന്ന് താഴെ നോക്ക്, മുകളിൽ വലത്തോട്ട് ഇടത്തോട്ട് പല്ല് കാണിച്ച് ഈ മതി. ചുമ്മാ വാ തുറന്ന് ആന്ന് പറഞ്ഞ് മതി
All characters were normal.
മതി. തലതാത്തോ തലതാത്തോ ബോട്ട് എൻ്റെ കയ്യിലോട്ട് തള്ളണേ. വെരി ഗുഡ്. ബാക്കിലോട്ട് തള്ളിയിട്ട് ബാക്കിലോട്ട്
Only positive level at time. Tone was normal.
എല്ല് പൊട്ടണം ആ കണക്കിന് പിടിച്ചാൽ
It was normal in both upper and lower.
മാക്സിമം വിട്ടോ 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 കൈ ഇങ്ങനെ കൊണ്ട് നൂർത്തെ നൂർത്തെ വിട്ടോ. ഇനി എൻ്റെ വിരലെ തൊട്ട് മൂക്കിൻ്റെ അറ്റത്ത് മൂക്കിൻ്റെ അറ്റത്ത് ചെയ്തു. എൻ്റെ വിരലെ തൊട്ട് മൂക്കിൻ്റെ തൊട്ട് പിടിച്ച് ഇനി മറ്റേ കൈ ഈ കൈ പെട്ടെന്ന് പെട്ടെന്ന് ഇങ്ങനെ
There is no finger nose incoordination. Cane is here.
ഇങ്ങനെ കാണിച്ച് ഇങ്ങനെ ഇങ്ങനെ ബലം കൊടുക്കരുത് കേട്ടോ.
tone was normal. It was water power normal.
ഇത് പൊക്കിക്കേ പൊങ്ങട്ടെ മതിവിട്ടെ ഇത് മടക്കി ചവിട്ടി ദൂരത്തെ ചവിട്ടി മാറ്റല്ലേ മുമ്പോട്ട് തള്ളു 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 ഓക്കെ ഇതേപോലെ തള്ളിക്കേ തള്ളി മാറ്റ് തമ്മിക്കൽ മുകളിൽ അങ്ങനെ പിടിച്ചോണം അത് പൊക്കി പിടിച്ചോ തള്ളവല്ല പൊക്കി പിടിക്കുക പൊക്കി പിടി ചവിട്ടിക്ക് എൻ്റെ കയ്യിൽ ചവിട്ട് ചവിട്ട്
Adduction normal.
തള്ളവല്ല ഒന്നും
What was forest totally normal.
ചേർത്ത് വെച്ച്
Rectessor also normal.
കീപ്പോട്ട് തള്ളു തള്ളിക്ക്
There is no lower limb coordination I could see. Yield test was negative.
മതി അതേമാതിരി കാര്യം കൊണ്ടിരിക്കുന്നത് താഴെ മുട്ടിച്ച് ഇനി ചെയ്ത് മതി
Reflexes were normal.
പകുതി 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 വാ പതുക്കെ തുറന്ന് മതി അങ്ങനെ ഇരിക്കട്ടെ അങ്ങനെ ഇരിക്കട്ടെ
Don't reflex intact. If you continue go fast, slowly reflexes all normal.
വിട്ടേ
Mandos were indefinite, reflexive. Sensations all normal. I think it go to the positive.
ഉണ്ടോ ഇല്ലയോ ഇല്ല ഇല്ലെങ്കിൽ എന്താ പറയാനുള്ള ഇപ്പോഴോ ഉണ്ട്
His sensations were grossly normal.
ഇപ്പോഴേ ഇപ്പോഴേ ഇല്ല ഇപ്പോഴോ
Okay, these are all normal.
ഇപ്പോഴേ
But this is the finding we got. He made to stand up. He walks something this kind of a gait and making to stand like that tends to fall, go backward. And diverting his attention with eyes closed, it goes backward like that. Said he has fallen many times backward.
അതിനെ എണ്ണിക്കോ മനസ്സുകൊണ്ട് എണ്ണണം കണ്ണടച്ചോ അതിനെ എണ്ണിക്കോ എത്ര പ്രാവശ്യം പൊട്ടിയിൽ എണ്ണിക്കോ എണ്ണിക്കോണേ നിങ്ങളുടെ ജോലി എണ്ണാന്നുള്ളതേ ഉള്ളൂ എണ്ണുന്നുണ്ടോ സെറ്റ് ചെയ്തത്
It's the gait of the patient. Can stand on heel and go.
പോയി നിന്നോ പറ്റും ഇങ്ങനെ മുമ്പിട്ട് പോകട്ടെ ആ ഇനി താത്തേ ഇനി ഇങ്ങനെ ഇരിക്ക്. മതി മതി ഇനി കളി ചേർത്ത് ചേർത്ത് വെച്ചു കൈ കെട്ടിക്കോ കൈ കെട്ടിക്കോ കേട്ടോ വീഴത്തില്ല കൈ കെട്ട് അത്
He's always fearful of falling.
ഇനി ഞാൻ നടക്കുന്ന പോയാൽ പറഞ്ഞതുപോലെ കേൾക്കണം കേട്ടോ സ്റ്റെപ്പ് എടുക്കത്തില്ലേ അതേപോലെ കൊടുക്കണം ഞാൻ ഈ പറഞ്ഞു
The tandem walking.
നടന്നോ കുഴപ്പമില്ല ചുമ്മാ നടക്കെ നടന്നോ നടന്നോ നടക്ക് വീഴത്തില്ല അവൻ കൂടെ നടന്നോ വീണ ഞാൻ നിൽക്കില്ല
Full test.
തള്ളാൻ പോവാണ് ആര് തള്ളാൻ പോവാ
So, an examination, lamellar tap was positive, circuits were normal, motor system normal, DTR absent angle check, otherwise normal. Pandas flexor, sensory impaired JPS over the left big toe and left little toe. Rhombox, you saw the rhombox finding, and on standing, the patient tends to fall backward. So, what do you think the patient is having, and what investigation like to do? Anyone?
Phobic vertigo.
Pardon? Phobic perspective. But he has fallen many times backward.
But later on you proved that he is not falling.
Yeah, at the point time he is not falling.
Has he got a truncal dystonia, sir?
No abnormal posturing per se. When he stands, he goes backward like this.
Yes, sir. And one of the time, actually, he was having some jerk also, no? Yes.
Yeah, correct. Some jerk also was there.
And then go back.
Okay, he came with this MRI. This is a lumbar spine. This is a cervical spine, normal. Dorsal spine, normal. This MRI of the brain. So what do you want to do now? He was in fact receiving Syndopa. So what do you think you'd like to do? So in fact, I put him just like Monsar thought. I also thought it is functional. Even though he gives history of fall, he never injured himself. So I put the patient on D-Venicep. And 2 weeks after the treatment, this is what he had. He developed tremor of the right hand. You see the tremor?
കൈ നീട്ടിക്കേ
The right hand, show the time once again.
താത്തെ
It appears sometimes like this.
ഇനി ഞാൻ പറഞ്ഞോട്ടെ അവിടെ നിൽക്കി ഞാൻ ഒന്നും പറഞ്ഞില്ലല്ലോ നിങ്ങളൊന്നും ചെയ്യാൻ പറയാം പറഞ്ഞ ഇഷ്ടം
When he diverts attention, disappears.
ഇങ്ങനെ
When he is asked to do some activity with the left hand, they get that time once the tremor becomes less than a second.
മൂക്കത്തോടെ വെള്ളത്തോട്ടെ മൂക്കത്തോടെ ശരി മതി ഇനി ഈ കൈ മാത്രം ഇങ്ങനെ കാണിച്ചു ഇടത് കൈ ശരി മതി കിട്ടാം
The gait abnormal, so-called gait abnormal, is still persisting, but he never fallen from chicken.
വെള്ളോട്ടെ വെള്ളോട്ടെ
So what is actually was having is subsequently the tremor had a hysterical tremor. So it's only a short case. Sometimes we were misled by that history of falls. What is actually doing was he's trying to sit because of the fear of fall, not actually falling. I think it's a short case only. I will go to the next case.
The tremor, what is the name of the tremor?
It's again hysterical. He's developing one symptom after another. He's totally acute onset. It disappears after diversion and doing some activity with the left hand. There are clue ways that absolutely no finding. Yeah, please. Yeah.
Then what is the phobic vertigo?
Yeah, this is a phobic postural vertigo, triple PD. But actually, yeah, you can call it triple PD. That's a phenomenology what the patient is having. The fear of falling. We went send the patient for psychological counseling. A lot of underlying psychological upsets in his family and things like that. That's made him do like that. Okay, I'll go to the next case. It's a 14-year-old boy. He's still difficulty in walking, getting up from squatting position for the last 1 week. No pain or paresthesia anywhere in the body. No upper limb complaints. No backache or root pain. No sphincter problems. But he gave diarrhea 2 weeks back. So difficulty in getting up and difficulty in walking for the last 1 week. This is the video of the patient. Failures are all normal. There's no facial weakness. Tone normal. Power normal.
മാക്സിമം പിടിക്കണേ വിട്ടു അവനിങ്ങനെ പിടിക്കുക നൂത്തി പിടിച്ചു ശരി അവനിങ്ങനെ വേറെ അകത്തി പിടിക്കും മോനെ ഞാൻ പറയുമ്പോൾ ചെയ്യണം അതിന് എഴുന്നേക്കാൻ നോക്കാം
Reflexes were normal.
ഈ കാല് നേരെ പൊക്കിക്കേ
He's able to get up and sitting.
മതി വിട്ടേ ഇത് പൊക്കിക്കേ
Flexing extensions were weak.
പാദം മടക്കിക്കേ എല്ലാം നമുക്ക് ഇനി ചവിട്ടി നൂർക്ക് എന്നെ ചവിട്ടി അങ്ങ് മാറ്റണം ചവിട്ട് ഇതൊന്ന് ചവിട്ടി മാറ്റി ചവിട്ടി അങ്ങ് മാറ്റി ഈ പാദം
Those reflexes were weak by that.
അതിനെ കീഴോട്ടാക്കാൻ സമ്മതിക്കുന്നേ
Weak by that.
പിടിച്ചോ മോനെ ഇന്ന് പൊക്കി പിടിച്ചേ മനസ്സിലായില്ലേ ഇതങ്ങോട്ട് സമ്മതിക്കുന്നേ
EHL was weak.
അങ്ങോട്ട് പൊക്കിക്കേ പിടിച്ചേ
Plantar flexion, relatively good power.
ചവിട്ടിക്കേ
On lying down.
ആഞ്ഞ് ചവിട്ടങ്ങോട്ട് മതി ഈ കാലം അകന്നിരിക്കണം
Reflexes and reflexes were normal.
മനസ്സിലായില്ലേ
On lying down. Then examine the leg.
അകത്താ സമ്മതിക്കരുത് കഴിച്ചിരിക്കണം കേട്ടോ എന്റെ കയ്യിലോട്ട് തള്ളു എന്നെ തള്ളി കീഴോട്ടാക്കുക
Reflexes was weak bilaterally. The reflexes were all on the brisker side. The little tilted in the upper limb. Down reflexes were intact.
തലയൊന്ന് പൊക്കിക്കാൻ
No Weber's sign.
മതി മുട്ട് മടക്ക്
Rejects were also brisk. Also angled jerk.
ഇങ്ങനെ കൊടുക്കാതെ
We get an adductor jerk. When you do the angled jerk, the adductors are also contracted.
ശരി കാല് നേരെ വരും.
Plantar was indefinite, not either upgoing or downgoing. Some panning on the toes is there, but otherwise no definite upper pan. Insides were all normal.
ഇതറിയാമോ എനിക്ക് ഇരിക്കലാണോ ഇപ്പോഴോ
Vibration normal.
ഇതോ ഈ വെല്ല് താഴെ മുകളിലൊന്നും പറയാതെ ഇപ്പൊ എങ്ങനെയാ ഇപ്പോഴേ
Not GP sensations normal.
ഇപ്പോഴോ ഇപ്പോഴോ ഇപ്പോഴേ ശരി
So that's the second part of the video, the gait of the patient. It's a gait, it's got some kind of a battling gait, but if it's rotating in it. He cannot stand on toes, stand on heel, stand on toes for some time. But not fully, he cannot stand up and go. He could not get up from sitting position with the help. Pendelberg was not that positive. So, for examination was upper limb tone power normal, lower limb tone normal, weakness of both knee extensors, dorsiflex of the angle, extensor radius longer, senip extensors, DTR all normal in the upper limb, brisk in the lower limb, abdominal reflex intact, Beaver's is negative, so negative. Gait, some kind of a waddling gait, could not get up from the squatting position, could not stand on heel, but could rise partially when standing on toes. These are the findings. So what do you think the patient is having?
Hyperreflexes GBS.
Okay, very good.
Second is cervical myelopathy. Third, polymyositis.
Okay, but he had no pain in the limbs and weaknesses proximal and distal in the lower limb with the upper limbs totally normal. Okay, so
Yes, sir.
pardon, any other possibility?
No.
Myeloradiculopathy with L5, more front is on the L4, L5.
Okay, so you think both pyramidal signs and element signs are there?
Yes, sir.
Okay, any other possibility?
Lumbar flexopathy, sir, because of asymmetric involvement.
Asymmetry is not there. Moreover, it's bilateral.
Posterior group of muscles are more involved than the anterior groups in the lower limbs. Knee extensors, it's pairing of other muscles and back. Predominantly hip extensors involved and abductors are spared. The patchy involvement is seen.
Okay, that patch involvement can occur in flexopathy, but do you think it is bilaterally without any pain in the limbs with the brisk reflexes?
Initially complaint of pain, no, sir, leg pain.
Initially complained of pain for a few days, correct? Okay, so these are the possibilities.
Just a post-viral myositis.
Myositis is also possible. Okay, because there's no sensory complaint findings in this patient refers to brisk, but there is no muscle tenderness per se. Okay, what did the patient was treated and his weakness improved? And see the follow-up video. I'll come to the test and or as
Potential, sir.
Pardon?
മടക്കിക്ക് മൂർത്തെ അത് തന്നെ
Let us see I'll tell you what we did here. How became normal in 2 weeks.
Potassium was normal, sir.
Potassium was normal.
ചവിട്ട് ചവിട്ട്
Did not improve in 1 day, improved over 2 weeks. Process remain brisk.
നേരെ വെച്ച് ഞാൻ ലൂസാക്കിയിടും മോനെ ഇവന് കൊടുക്കരുതേ ലൂസാക്കിയിടണം
Okay, I think I will skip that rest of the video.
മോനെ
See the gait of the patient is called waddling. It that also improved.
There is dragging. Was he having a cerebral palsy or something?
No. He was perfectly all right prior to that. He improved.
ശരി മോനെ വാ
No, he's improved. He's not totally normal, but still much better. Say plantar power is good. So, what do you think might have happened?
Probably GBS only.
Okay, right. So, let us see the finding, GBS finding and CBS. So, it's got decreased amplitude in the proximal stimulation, that is got a conduction block. Distal latency is normal, conduction velocity is normal. Left peroneal again, amplitude is decreased, but more so by proximal stimulation. Again, with the left peroneal. Right tibial also has got a conduction block. So also left tibial. Gross difference is there between the distal and proximal stimulation. So it's got conduction block in the multiple peripheral nerves. However, the upper limbs were entirely normal. Sensory potentials are all normal. FAs are also normal. So what is the likely diagnosis in this patient?
Hyperreflexes GBS.
Okay, but with the conduction block, do you expect normal distal latency, normal conduction velocity, and normal FA in GBS?
Yes, sir. Because last time you,
Pardon?
last class you told on the.
Depends on the site.
Exactly. That this is not GBS of demyelinating type. This is not AADP. This is nodopathy. There is no prolongation. That's again, ADP should have demyelinating pattern, should have instance of prolongation or a conduction loss in prolonged FA. None of them were present in our patient. This is not of the last class. I brought the case to exemplify a case with the case today, this week. This is a reversible conduction block. Because what happened? Pardon? That is why he has improved within 2 weeks' time. In fact, if you take the GBS pattern, this electrophysiological pattern of this thing, you think it's likely to be ADP because the conduction block. But why the other parameters are all normal? Latency normal, velocity normal. So that shows this block is, and the patient's improved. So this is someone with reversible conduction block. A good prognosis compared to the pure axonal type of MI. No, I did the NCVs 2 days as well as 3 weeks later to find out reversibility of the conduction block, but it was not. It was still persisting even after 2 days and 2 weeks later also. This is after again, but all the time there was no prolongation, there is latency. Never the patient had any prolongation of latency or conduction velocity slowing or any FA latency flow. This is on 25th November, that is 3 weeks after the came for follow-up. Again, you find that there is conduction block is remaining, but the distal latency, conduction velocity, FA latency continues to be normal. That is not the pattern in the case of demyelinating, AADP pattern. When you follow up, at least you get prolonged FA latency and prolonged distal latency prolongation. These are all normal in the follow-up. This is the 881 and this 21.5. The parameters showing the same thing. Only conduction block, other parameters remain normal. So this is what is called GBS with intact reflex or brisk reflex, as Parameshwar was telling. Now, why are the detail not lost in some cases of GBS? See, according to the criteria, you should have a reflex here to diagnose GBS. But that may not be lost. Sometimes it may be brisk also. This is because deep tendon reflexes rely on relatively synchronized volley of impulses and are more dependent upon the normal sensory than motor fibers. The sensory fibers are not affected, only motor fibers are affected. The reflex loss is pari passu with the degree of motor loss. With a severe motor loss, reflex will be lost. But only partial loss, reflex may not be lost. Therefore, a motor axonal disorder like a MAN, not involving the sensory afferent arc or the stretch reflex, is suspected if affecting only a fraction of axons to preserve the tendon jerks more than a demyelinating disorder as AADP, which desynchronizes both sensory as well as motor volleys of impulses. Mild to moderate weakness can also explain the preservation and earlier reappearance of DTR. I think this part I will skip. So why there is some explanation why the reflex, that will explain why the reflex is preserved. That will not explain why the reflex have become brisker. So this is again another point. The electrophysiological studies have showed high soleus maximal H reflex amplitude to maximal CMAP amplitude ratio, suggesting that the spinal motor neuron hyperexcitability and increased central conduction time suggestive of a cortical spinal intact involvement, although a structural damage was never demonstrated by MRI. This is from literature only. This again literature review. I think I'll skip all these things. And this type of presentation is more likely related to the anti-glycosid and antibodies. But this type in hyperreflexia with Guillain-Barré syndrome, anti-glycosid antibodies are positive in nearly 90%. It was generalized 90% associated with reflex spread. Then I think this I will skip. Skip all these things. Okay, any questions on that before I go to the next one?
Did you treat with rituximab?
No, I already gave plasmapheresis.
Okay.
This is only to bring to notice that a brisk reflexes need not make you think away from GBS. So that we should not blindly follow the criteria to diagnose AAD. Sometimes it can occur in the GBS presentation of command type. Okay, then we'll go to very.
You treat him with him, sir?
Please.
What did you give him, sir?
Give him plasmapheresis.
Okay, sir.
This is a very interesting management problem. It's a long story. The 37-year-old pastor first seen by me on March 2022. But the history was quite long. His first problem started in 2015. That means 7 years back. As double vision and blurring of vision, which was more towards the evening. He was seen by a doctor who detected ptosis of the right eye. These two complaints persisted for the next 3 months. After 3 months, he was seen in a major hospital and was put on Gravitor, that is pyridostigmine, and the diplopia improved partially. He remained relatively all right for the next 3 months. After 3 months, following excessive strain in the eye and stressful life situation, his symptoms of diplopia worsened and was seen in another hospital, another medical college in Bangalore. There, a new statement test was said to be positive, but the RNS was negative. He was continued on Gravitor and neostigmine, but the symptoms persisted. In 2018, again following a stressful situation, symptoms worsened and he was submitted for thymectomy. Following thymectomy, his symptoms improved totally for the next 4 months. After 4 months, patient symptoms worsened again and was started on Visalon 10 mg OD with a plan to hike up the dose, and the dose was subsequently increased to 30 mg OD. Since the symptom persisted, that is azathioprine was added in a dose of 50 mg BD along with 30 mg Visalon. Even on the same medication, continued to have fluctuating symptoms. Sometimes he felt better, on other days it was worse. In March 2020, he started developing drooping of the head along with drowsiness, usually at 10 to 11 a.m. The drowsiness and drooping and then used to last for about 10 to 15 minutes. Even after recovery from the drowsiness, he was feeling prolonged fatigue, which hindered his activity. He occasionally developed subjective weakness of the right upper limb and feeling of buckling of the knee, but he has never fallen down. He underwent sleep study and was advised CPAP. On CPAP, his drowsiness improved, but the drooping of the neck persisted. His toes diplopia persisted, and then that's why he landed here. So this is the story. It's a long story. So you want to hear the story once again, I think, or we can go to the rest of the findings.
Once again, sir.
Okay.
Antibody was never positive, sir. Antibody was.
And this I'll show the report later on. I'll show the report also. But the story is like this, a long story. Started 7 years back as double vision, blurring of vision, more towards the evening. Then 3 months later, he was seen in a major hospital, put on Gravitor, remained all right for the next 3 months. After 3 months, following excessive strain in the eye and stressful life situation, his symptoms of diplopia worsened and was seen at the medical college in Bangalore. Their immunostatement was said to be positive, but RNS was negative. He was continued on Gravitor neostigmine, but the symptoms persisted. In 2018, again, following a stressful situation, his symptoms worsened and submitted for thymectomy. Following thymectomy, symptoms improved totally for the next 4 months. After 4 months, since the patient worsened again, he was put on Visalon, which was increased to 30 mg. Since he did not improve totally with Visalon 30 mg, azathioprine was added Even on the same medication, he continued to have fluctuating symptoms. Sometimes he felt better, on other days it is worse. In March 2020, he started developing drooping of the head along with the drowsiness, probably due to the drowsiness itself. But he said it is drooping and drowsiness simultaneously. Used to last for 10 to 15 minutes. Even after recovery from the drowsiness, he was feeling prolonged fatigue, which is hindered his activity. He occasionally developed subjective weakness, but there's no objective evidence. He has dropped things from his hand and feeling of buckling, but never fell down. Then he underwent sleep study and was advised CPAP. On CPAP, his drowsiness improved, but drooping of the neck episodically persisted. It also diplopia persisted and then came here. So I'll show the finding when he came here. That is in March 2022. This is his, I did the examination. With the fatigue testing, asked him to look up for a prolonged period of time. His right eye used to drop down. Ask him to forcefully open the eyes, he could only open it partially. The strain is maximally tight. Ocular movements are all normal. Even the combined diplopia, I could not detect any obvious. Looking maximum on looking up, it was there. Orbit lens is normal. There is no obvious fatigue phenomenon. I mean, immediate fatigue. Long looking up, he's got a fatigue with the right. So what do you think the patient might have been had before I show the investigations done earlier? Myasthenia? Okay, let us see. Now go back to the history again, once again, one by one, show the investigations. In 2015, he was diagnosed with ocular myasthenia in a hospital, but no records available. In 2016, he was admitted in another hospital. There, the findings was I think we'll skip the report. This is RNS done at that hospital. It was done on the facial. This is on the right facial. This is right orbicularis. This is the abducted digitae minimi. Left facial. So I'll come back to this is the right facial. Right orbicularis. ADM. Left facial. And the report repeated RNS study was done on left ulnar, both facial and left spinal accessory nerves. Study shows decremental response from the right orbicularis ocular muscle, which you can see there. So this is the conclusion. So first, that's why he put on treatment. He was admitted to another hospital in Bangalore. This is the case record. They returned double negative myasthenia, which antibody was done at that hospital. SHR antibody as well as MuSK antibody was done, which is both were negative. So they called this double negative myasthenia. Okay, in 2018, admitted another hospital for thymectomy. It's already in the history has already been given. So the biopsy from the thymus, they shows no specific lesion. They say sub-involuted thymic tissue with no specific lesion. In 2019, admitted in another hospital. There they did a NCS was done, which is grossly normal.
One doubt.
Yeah.
The fatigability test that we do, no?
Yeah.
Like, can it be like this asymmetrical? I have never seen that one eye is becoming so.
That is well known. Myasthenia can
Okay.
be confined only to one eye, may not necessarily be both eye. It can be confined to one hand alone. As I said, myasthenia presenting as a stroke. So this is sensious as normal. So repeat RNS was done in that hospital. Then the third hospital, there this RNS finding, which is normal, did not show any decremental response. He was on treatment at that time. MRI brain was done. No significant abnormality detected in the brain. Polysomnography was done in another hospital for his sleep. They detected, study showed evidence of severe apnea, hypopnea without desaturation. Resultant arousal of RDA 21.06 per hour. Short features such as severe OSA, that was their conclusion. I was put on CPAP. So multiple sleep latency study was also done, which showed pathological hypersomnolent state. Patients continued on perilous treatment and added azathioprine that with that investigation. 2021, they was admitted in another hospital. There, they detected right partial ptosis and then low backache was there. And they did MRI of the whole spine screening because of its decreased reflex on the left side. They found some disc protrusion, osteopathic compresses compressing the right paracentral protrusion C5, C6, and L4, L5. So that is totally unrelated to our problem. The final diagnosis at the hospital was myasthenia gravis status post thymectomy on immunomodulatory and immunosuppressant therapy, not in remission. Diffuse disc disease with neural foramen narrowing, diabetes mellitus, hypertriglyceridemia, ptytosis, OSA, hyperuricemia. I think this hospital course I will skip. So they planned injection rituximab being planned to give to comfort rituximab. So that is why it's admitted again 2022. Another hospital, that's all. So now the patients come to you. This is the background story. The investigation was done in this patient. So what do you want to do now? So in the OPD, I did the ice pack test. So this is before the ice pack test. I showed. When you develop the ptosis, I applied the ice pack. The patient has ptosis. Then after the ice pack, his eyes opened and remained for a longer period of time before he developed the ptosis. It developed quickly now after ice pack. It did develop, but after a long period of time. Okay. The fatigue to occur. So I asked the patient to come for admission after stopping all medication for 3 days and then come for admission. Unfortunately, he developed COVID and could not come up after only could come back only after 1 month. So he was, as promised, he stopped all medication for 3 days and came for admission. This is at the time of is admitted after stopping all medication.
All medication for 3 days now. 3 days. No medication for 3 days.
The same thing is developing again in human faster. Now, what do you think now? What do you want to do now? What test?
Any atrophy of the muscles, sir? Any atrophy of the temporal or the arm muscles, sir?
No, upper limb muscles are all normal.
Could it
OPD
be one
nearest
type
next.
of the congenital myasthenia syndrome, so one of the syndromes where they worsen with this myasthenia?
No, but congenital myasthenia, you want to suspect this patient?
Myasthenic syndrome, sir, congestal myasthenic syndrome, CMD1A or 2A, where
Yeah, but
they
okay, right. But he did improve in between with treatment.
yeah, they can improve with sometimes they can improve with
With the
signal and version also.
Okay, that you think that's a congenital myasthenia syndrome. Okay, right. Nobody can
Many
see.
mitochondrial myopathy, some kind of mitochondrial
No,
myopathy.
it's not myopathy. Myopathy is always symmetrical, and they won't complain of diplopia. They will not develop this fatigability. This is
OPD
what-
nearest test, sir.
Pardon?
OPD nearest test, sir.
OPD neostick test. Okay. So, as Ramesh was telling, I took him for neostick test. My plan was to give injection when the patient there is maximum fatigue to see the response. So, this is test was done.
ഇപ്പോൾ ഇഞ്ചെക്ട് ചെയ്യില്ല ഞാൻ പറയുമ്പോൾ പൊയ്ക്ക് മുകളിലോട്ട് നോക്കിക്കൊണ്ടിരിക്കുക ആ ടോസിസ് വരുമ്പോൾ വേണം ഇഞ്ചെക്ട് ചെയ്യാനായിട്ട്
I waited for the ptosis to develop
പോട്ടെ പോട്ടെ
and injected. I'll show you.
ഞാൻ വീഡിയോ ഓഫ് ചെയ്യരുതേ ഞാൻ പറയുമ്പോഴേ ഇഞ്ചെക്ട് ചെയ്യാവുള്ളേ ആ വീക്ക്നെസ് വരുമ്പോൾ വേണം ഇഞ്ചെക്ട് ഇനി ഇഞ്ചെക്ട് ചെയ്തോ
No, I injected now.
അത് മാറുമെന്ന് നോക്കട്ടെ എടുത്തോ ആ
Even?
വെയിറ്റ് ചെയ്യ് ഒരു 30 സെക്കൻഡ്സ് വെയിറ്റ് ചെയ്യുകയാണെങ്കിൽ ഇമ്പ്രൂവ്മെൻ്റ് അറിയാൻ പറ്റും
Then waited for 30 seconds or up to 1 minute.
തുറക്കാൻ ശ്രമിച്ചേ
Ask him to try to open the
തുറക്കാൻ
eyelid.
ശ്രമിച്ചേ ഇമ്പ്രൂവ്മെൻറ്റ് നോട്ടെ പറ്റും നോക്കട്ടെ ആ ഇമ്പ്രൂവ്മെൻറ്റ് വരുന്നുണ്ടല്ലോ ഒന്നുകൂടെ ശ്രമിച്ചേ ഒന്നുകൂടെ ശ്രമിച്ചോ
Ask him to
ഒന്നുകൂടെ
try to
ശ്രമിച്ചേ
lift up.
30 സെക്കൻഡ്സ് ആയോ ആയി വരുന്നുണ്ട് 30 സെക്കൻഡ് ആയി 20 സെക്കൻഡ്സ് ആയതേ ഉള്ളൂ 20 സെക്കൻഡ്സ് ആയി ശ്രമിച്ചാൽ പറ്റും ഒന്ന് നോക്കിക്കേ നോക്ക് നോക്കിക്കേ ഇപ്പം ശരി കുറച്ചുകൂടെ ശരിയായി ഇപ്പം ശരിയായി വെരി ഗുഡ് ഓക്കെ വെരി ഗുഡ് ശരി ഇപ്പം ശരിയായിച്ചോ ഇല്ലേ ഓക്കെ വെരി ഗുഡ്
Okay, what is the diagnosis now?
It is positive, sir.
Okay.
Sir, when
Yeah.
he was having drooping of the eyelid, his eyebrow was also going down.
Yes, that's
And when his eyebrow is going up after the neostigmin, when the eyelid is going up, his eyebrow is also going up. And there is a lot of twitching. So is it functional?
Okay.
Yes, I also think like that because the movement of the eye is something like a twitching rather than a real ptosis.
Okay, perfect. You know, what you said is correct. The test was positive, but I did not give the neostickmin. I gave only injection saline. So no, this injection was only saline.
And neostickmin will take more time.
No, not because of that.
Not only that, the movement of the eye, the ptosis is not the real ptosis of a myasthenia. Here some twitching.
Yeah, it's as Butch and Bindu was telling, it's perfectly right. On the first video itself, I'll come to that. So to fool these patients, always I told him that I'm going to do a neostickmin test, but gave only saline to find out, and then coax him, it will become all right and all. So I did not inject saline. He's responded with saline. Now there was some necessity for doing it. In fact, I loaded neostickmin also in my hand. So anyway, I gave it. Anyway, it's loaded. I tried it with that also. It's same effect. So that worry of them. So what made me suspect the function? That is, as which was telling, had fluttering of the right eyelid, which would not occur in the if the LPS is fatigued. If any myasthenia, when the muscle is fatigued, why should it go up again? It should go gradually comes down. As long as patient trying to keep it elevated, it's not produce any fluttering of the eyelid. Second point, as again, which was pointed out, the eyebrow is still low even when he developed the ptosis and looking long time. Let us see the video once again. See the first video when he came to OPD. See, look at the eyebrow on the right side when he develops the ptosis. This is coming down. Normally it should have been going up. Then attempt to elevate the eyelid should go up. On the other hand, right eyebrow is down. And see
The left, he is raising the left eyebrow actually.
Correct. Correct. So actually, it's only functional process. So in fact, so that's the story. Then I'll come to the explanation for the diplopia later on. So in fact, I sent for a clinical psychologist. A lot of problems in the, that what you call parish said that he did not want to continue in that thing. That's a lot of problem behind. She ultimately improved with suggestions and mild anti-anxiety agents. Now, another question is, why did you develop diplopia? Okay, ptosis I can understand. Diplopia is why it should be there. So what else you like to do to find out the cause of diplopia? The commonest cause of diplopia and prolonged reading is a manifest latent skin. At this point, I have told many times, many people have this problem. So I did the cover, uncover, and alternate cover test. So this is the patient. I'll show. Right.
വെള്ളി നോക്കണേ വലത്തോട്ട് നോക്കേ
Ocular movements now is normal on the right.
രണ്ടായിട്ട് കണ്ടാ പറയണേ
Left side is normal.
മാറ്റരുത് അവിടെ തന്നെ
That is the position of diplopia he was complaining. The cover, uncover, it test is negative. That means it is not a manifest or a diplopia. Now I'm doing the alternate cover test. That shows the deviation of the eye. And you don't know whether you can make out the eye deviating medially on the left side. Like anything.
നോക്കിക്കൊണ്ടിരിക്കണം അറ്റത്ത് അറ്റത്തന്നെ
On the left eye, that makes it goes medially. So that is why, so his cover uncover test, no deviation. Left eye goes into adduction, showing a heterophoria or exophoria. So that is why he's having episodic diplopia all the time when he's reading for a long time, when he's stressed for a long time. His the skin, the latent skin become manifest, causing the diplopia. Okay, so that's the story of this patient.
That's why I asked first when the examination.
Vindu, your voice is breaking.
That's what, sir. The first examination itself, that he was fluttering the right eye.
Correct.
And asymmetry, it was not okay. That you whatever you told, that is okay. But that fluttering with the eye and no compensatory lifting of the eyebrow is something odd.
Yeah, that's a clue to suspect this thing. But before that, I have to confirm, no, this is functional. So you cannot just say send the patient, because he has been treated in many places with immunosuppressant. Or it have to be very definite. That is why I did the saline test.
Yes, OSA ഉണ്ടെന്നുണ്ട് സാറേ.
Yes, what do I say?
ഒബ്ജക്റ്റീവ് എവിഡൻസ് ഉണ്ടല്ലോ.
Just objective evidence is there.
Yeah, Cogan's lid tissue sign. What is the explanation, sir?
The elliptic sign in myasthenia gravis. Okay. In myasthenia gravis, what happens is that when there is initially in myasthenic syndrome, the initial contraction is good. After that, it fatigues. So the patient is looking down and suddenly bring up. It overshoots and then coming down. Then muscle fatigues and come back. Why it's overshooting is because the postulated mechanism is that the brain is calibrating or it's anticipating the already fatigue. So there is the predetermined excessive innervation going to the muscle. The brain is already tuned to give excessive innervation. So it transiently makes it up, but it fatigues and comes back. That is why the elliptic sign is explained. I don't know whether made you understand. So in fact, yeah, because already the brain is recalibrated to give extra input to make the fatigue muscle contract. But the fatigue is not there all the time. So in the beginning, it is not this, it shoots up, then come back.
Yes.
Any questions?
ഇത്രയും കഷ്ടപ്പെട്ട് കൈമാറ്റം ഒക്കെ ചെയ്തല്ലേ.
സാർ ഒരു കാര്യം ഞാൻ പറഞ്ഞു സാറേ.
Yeah, please.
സാർ ഇങ്ങനത്തെ കേസ് സാറേ, ഈ ഒരു നമ്മളെ ഈ പെരിഫറിയിൽ ഇരിക്കുമ്പോ സാറേ വെരി ഡിഫിക്കൽട്ട് ടു സ്റ്റോപ്പ് മെഡിസിൻ സാർ. Because
the patients only has got eye problem, no much. Many systemic.
സാറേ എങ്ങാനും നമ്മള് ഭാവിയിൽ എങ്ങാനും എവിടെയെങ്കിലും ഒരു ക്രൈസിസ് അടിച്ചാൽ പിന്നെ അവര് നമ്മളെ കേസ് ചെയ്യും സാറേ.
The problem is crisis can occur only if the muscles are affected. Other muscles are affected. It's only ocular muscle only is there, no? Never had any respiratory problem. That we can control. But do that when the patient is admitted in the hospital. Then you can do the medication. That's what he did.
അത് ശരിയാണ് സാർ. എന്നാൽ നമുക്കൊരു ഭയമാണ് സാർ.
But we continue medication with that.
അത് ശരിയാ സാറ് പറയുന്നത് കറക്റ്റ്. പക്ഷെ നമുക്കൊരു
change the 80 years you have been going. But see, you are changing your entire scenery, no? And you become totally normal.
ആ കൈമറ്റമിന്റെ സമയത്തെങ്കിലും അയാൾക്ക് നോർമൽ അഭിനയിക്കുന്നില്ലേ?
Saline myasthenia test is very good.
Sorry. That I told the patient I'm going to do a myasthenia test, and he injected saline.
He must have read about all these things, no?
He's a passer, he knows all these things.
Yeah.
You have to tell that if you say saline, then he will not do this thing.
ശരിക്കുള്ള ന്യൂറോളജിനേക്കാളും കൂടുതൽ വളഞ്ഞ ന്യൂറോളജി പഠിക്കണം.
Okay, shall I go to the next case?
Sir, one doubt.
Yeah.
Sir, in the real myasthenia gravis, even if there is no thymoma, if we take out the thymic tissue, will there be improvement?
Oh, absolutely. That is why you do even thymic. That these people will improve much better than those with thymoma. Those with thymoma and myasthenia, the improvement is much less with thymectomy than those myasthenia gravis patients with thymic hyperplasia. Sometimes you can totally stop it. I have seen patients who could stop all medications, even immunosuppressants, following thymectomy. Not all, some.
Guideline is also like that, no? Even with thymoma also you have to do.
അങ്ങനെയുള്ള പേഷ്യന്റ് there will be some hyperplasia on biopsy.
Yeah. Okay. Shall I go to another case?
Yes.
Any more questions? I will go.
Yes, sir.
Okay. This again another case of ptosis. The story of a 30-year-old male. He again was on myasthenic medication. He complains of vertical diplopia in 2016. That is 8 years back, which improved in 1 week's time. In 2018, the 2 years later, the same symptoms occurred, which also improved in 1 month's time. Presently has noticed diplopia for the last 10 days, and the bystanders noticed ptosis of the left eye. That is how it came here. It's a short story. Vertical diplopia for 8 years back, which improved in 1 week's time. Then 2 years later, the same symptoms recurred, which also improved in 1 month's time this time. Presently noticed diplopia along with ptosis noticed by the bystanders. So this is the patient's video. You can see the ptosis on the left side. Eye of the position. Looking up, the ptosis is corrected and there is restricted elevation in the left eye. Looking down.
എങ്ങോട്ട് പോകുന്നു നോക്കി കാണണേ, നോക്കിക്കോണേ. കണ്ടാണല്ലോ അങ്ങനെ ഇരിക്കട്ടെ, കേൾക്കില്ല ഇത്. ഓക്കെ, ഇനി ഇങ്ങനെ കൊണ്ടുവന്നേ. എൻ്റെ കൈ മറയരുതേ. രണ്ടാണല്ലോ, ഇപ്പോഴും രണ്ട്.
Looking up. There is single. There is two. In two.
ഓക്കെ,
Again, pupil is normal, reacting well to light.
There is no anisocoria. Eh? Divya? There is no fatigability.
No fatigability of that either eyelid nor for the ocular movement.
In fact, it overcorrects. See, the eyes, clear eye is visible above the eyelid.
Okay. So, what is your diagnosis? He has got findings, I'll tell you, he has got ptosis, which are looking at it disappears. Ocular movement, restricted upward movement, both in the adductor and abductor position on the left eye. And diplopia also looking maximally looking up and out and up and in. So, on examination, towards left eye, also chorea on the right side. Restricted elevation, pupil normal, no fatigability. This is a diplopia, this is the patient sent by the ophthalmologist. This is a diplopia chart which they sent. So, what is the diagnosis? Any professional diagnosis you want to keep? Myasthenia? Why everybody suddenly becomes
Myasthenia also can occur.
Possible.
Myasthenia is possible. Okay. Any other possibility you want to keep? Okay. So let's see the. So what test do you want now? RNS? Okay.
Yes.
This is the RNS edit, which is normal. No decremental response. Then what else you need?
Thyroid function.
Thyroid function normal. Antibody you want?
Yes.
Antibody is positive. That is not grossly positive, 0.48. Upper limit is 0.4. They also, I don't know, they did anti-MOG antibody. These all results, patient came with these results. Okay, now what do you want to do? You put the patient on treatment or then do something else?
CT or MRI orbit.
Okay. So before the neostigmin test?
Yes.
Okay. So this is before neostigmin.
Before neostigmin. Before neostigmin,
It's a before neostigmin.
the range.
That's a range of movement.
Two slow to two. Before
That is after 1 milligram of neostigmin, IV. That's again no improvement. No neostigmin test is negative. Now, what do you want to do now? Pardon?
MRI of the orbit.
MRI of the orbit. Okay. MRI of the brain and orbit. We can take both. Okay. So the MRI of the brain was done. Find out whether any partial nucleus involvement in the brain stem. That is normal. This is the T2-8, I think. This is the coronal cut for orbit in the muscles. There is no atrophy or hyperplasia of the muscles. No lesion. This is the cis sequence to find out the third now. This is the third now, which you can see there. That is quite normal on both sides. Now, what do you want to do? Send the patient with the newest trial of pyridostigmine.
Cover and cover.
Yeah, sometimes orally with oral they will improve. Neostigmine test they may not improve.
But I did not get you. Tell me.
So sometimes with neostigmine test we will not get improvement, but with oral pyridostigmine sometimes they will improve.
Yes, that I have seen. I have seen. In fact, I have seen. Okay, but the patient came with oral pyridostigmine without an improvement. But they only give for a short period of time. Then I can decide about that.
Alternate cover test.
No, that's why we can do that because, but already there's a pakka restriction, and that of course that's a possibility we can do. There's also dose is also there. Okay, let us see.
Could it be restriction down the entrap?
No, downward movement is normal. I can show the video once again. It's elevation.
എങ്ങോട്ട് പോകുന്നു നോക്കിക്കാണേ നോക്കിക്കോണേ കണ്ടാണല്ലോ അങ്ങനെ ഇരിക്കട്ടെ കേൾക്കില്ല ഇത് ഓക്കെ നീ ഇങ്ങനെ കൊണ്ടുവന്നേ എൻ്റെ കൈ മറയരുതേ രണ്ടാണല്ലോ ഇപ്പോഴും രണ്ട്
ഒന്ന്
Okay, downward movement is normal. The elevation is restricted. Updated is normal. That is a restriction. Okay. So, Bindu, you like to put on pyridostigmine. Any other opinion? What to do with this patient?
Can it be Mobius with the manifest skin?
Manifest latent skin is possible, but yeah, looking up. Correct, that's a possibility. But for that, we can do that. Let us analyze this problem. What is causing is vertical diplopia and restricted elevation. That is point number 1. Second, what is causing is ptosis. Now, let's see the restricted elevation first. First thing to find out whether it's due to the real paralysis or not, or as Monsar was telling, is it a manifest latent skin? That's the first thing to sort out why it's not moving up. So, what test will you do? As suggested, you have to do duction testing first. So, this is a duction testing. Posting each eye looking for the movement. The movement is restricted even on closing one eye. I'll compare with other eye, I'll tell you.
Okay, ini kanda.
That is a normal right side.
ശരി.
What I did was I had to find out.
ഈ പോസ്റ്റ് നോക്കണേ ഇരിക്കണം കേട്ടോ ഇതെങ്ങും നോക്കരുത് ഡോക്ടർ ഈ വെള്ളി നോക്കണമേ നോക്കിക്കൊണ്ടേ ഇരിക്കാവൂ നോക്കിക്കൊണ്ടേ ഇരിക്കണം കേട്ടോ ഈ വലത് എന്നിട്ട് ആ വെള്ളി നോക്ക് മുകളിലോട്ട്.
Yes, real restriction of upward movement. See, if we had been focusing with the right eye, as left eye is a lazy eye, on closing the right eye, the left eye should have moved up to catch up the fixation. that means that the restriction of elevation is not due to a latent script. But the reduction moment also is restricted. So that point is, now we know that there is restriction. So such paralysis means in the paralysis of superior rectus and inferior oblique. So whenever there is a paralysis of any group of muscle, first you have to suspect whether it's LMN or UMN. As you know, human palsy is conjugate, should be bilateral. So it's unlikely that a human gaze palsy is responsible for that. Usually you don't get it. But there is a condition called monocular vertical gaze palsy. That vertical gaze palsy sometimes can be confined only to one eye. This is because of the lesion from the RIM, when one side is affected alone, sometimes it can produce a elevation restriction on one eye. That is described. So what test will you do to find out whether it's a monocular vertical gaze palsy or not? There are two tests which you can do, vertical VOR and Bell's phenomenon. So I did the vertical VOR.
The camera തന്നെ നോക്കിക്കോ.
In VOR also the eyeball is not
അവിടെ
moving.
തന്നെ നോക്കണം. തല മുമ്പോട്ട് കൊണ്ടുപോവാ.
Still it is, if compared to the right, it is not moving up at all. So VOR also showing position of the eyeball not corrected.
Okay, മതി.
So that other things which I can do the Bell's phenomenon.
ഞാൻ പറയുമ്പോൾ കണ്ണ് മുറുക്കി അടയ്ക്കണം. ഞാൻ പറയുമ്പോഴേ അടയ്ക്കേ.
Left eye is not moving up.
ഓക്കെ, വിട്ടേ. ഒന്നുകൂടെ അടച്ചേ. Okay.
So that means it is not a gaze palsy. Monocular gaze palsy describes some other condition. I'll come to that later on. So this is not a gaze palsy. So it indicates that there is a real paralysis of the superior rectus and inferior oblique on the left side. Again, LMN lesion. So both tests rule out a monocular vertical gaze palsy. Now let us see analyze the ptosis now. What is causing the ptosis in this patient? Is it levator palpebral superior weakness or Horner syndrome or something else? Let us see this one. On looking up, ptosis get corrected. There is no ptosis. It becomes equal. It's a correctable ptosis. So when there is a correctable ptosis, it cannot be LPS weakness. And looking down also, you look at the position of the eyelid, it is same on both sides. It is corrected. From looking up, look at the position of the left eyelid and right eyelid. Looking down, it is same on both sides. That has got some significance, I will tell you later on. So, is it Horner syndrome or LPS weakness or levated excess? These are the three things which you have to keep in mind. It is not LPS weakness because the eyelid excursion is normal and the ptosis is totally corrected looking up. When the ptosis is there and that is totally corrected, you have to keep two possibilities. One is Horner syndrome or levated excess. So these are two possibilities. It is not levated excess because on looking in levated excess, on looking down, that toast eyelid is still lower compared to the other side. Elevated excess. In whatever be the position, looking up or looking down, it to be corrected because of the real contrast of the LPS. The primary position looking down, or even the lowermost position, the way looking down maximally, the left toast eye will be little lower compared to the other side. Let's see because on looking down, the eyelid margin is at the same level. Elevated excess, the affected lid would be lower compared to the other eye. See this position which I have shown earlier. If it had been levated excess causing the ptosis, this eyelid should have been more lower compared to the other side. So it is not levated excess, it is not levated palpebral superior. Then could it be left Horner syndrome? Could be, but pupil is not myotic. So that makes it less likely. But there is no, I can't think of a condition producing Horner syndrome plus elevated palsy on the left side. I mean, two different localizations, pretty odd. Now, what else could be? It's what's called pseudotosis. What is pseudotosis? Is the appearance of a droopy eyelid caused by the eyeball being hypertropic, downward displaced. Here, the patient's elevation is restricted, and the eyeball is lower compared to that of the right eye. So that eyelid also lower. This is because when the eye looks downward, eyelid is also the lower naturally. So that appears something like a ptosis, which is actually not a true ptosis. It's only because the support is lower, the eyelid has come down. So here the ptosis is due to hypertropia, second into the levator palsy. So elevator means elevators of the eyeball. So could be congenital. What else you would like to do? No. This upward elevation can be congenital. That's our next problem to sort it out. We know the ptosis, pseudotosis. The only problem is elevation is restricted. Anything you like? Oh, exactly. So this is the picture taken 2022, last one here on the right side. So on the left side here. This is taken 7 years back. It's got ptosis still there. Let us see the 2010 keratosis. 2000
be congenital, sir, because he had retraction of his eyes when he was trying to look down.
Correct. There's another point that the eye was having some mild retraction looking down. So this is, but there's one problem in congenital ptosis, Joy, because in congenital ptosis, in looking up also it will not be corrected. There will be a mild ptosis persisting. Here is totally corrected. That means it is not a problem of the levator at all, because that is fully functional. So that does not make it a congenital. Your point is taken. That's a point favoring congenital ptosis. That is there in this patient. But since it's totally corrected, yeah.
Is it a retraction of the inferior rectus or something? Contract of inferior rectus?
No, I'll come to that. Okay, so this, see, look at the page 2006. Still he had the ptosis. So this ptosis has been there from the very beginning. The ptosis has, Joy was still, it could be congenital, but the problem with the congenital ptosis is that it is still there, it disappears on looking up. It goes up fully. So that means it is not a congenital ptosis. Now let us see now, this is called double elevator. I had shown one case before. It's called double elevator palsy with pseudotosis. Now, double elevator palsy, so that's called monocular elevation deficiency, also known as double elevation, is an inability to elevate one eye above the horizontal plane. There are varying degrees of severity from misalignment only in the upward gaze to the deficit affecting straight ahead gaze, resulting in hypotropia as in our patient, one eye that is pointed downward late to the other eye. Now, this is one of the manifestations of congenital innervation dysgenesis syndrome. This is again from the literature, I mean, from this thing. You can see the pseudotosis on the left side because the left eye is lower now. That is why it appears not true ptosis, it's a pseudotosis. Okay. Then in case of double elevator palsy, there can be ptosis, can be true ptosis or a pseudotosis. True ptosis seen 25 to 75% of the time. In most of the remaining cases have pseudotosis because of the downward position of the eye. Okay, I think let's skip that thing. No, these are all points I will skip. Now, these patients can present with this about from the double elevator palsy. Ptosis can be associated with hypertrophy because of the facial attachments between the levator part of the superioris and superrectus muscle. Pseudotosis and true ptosis, both components can be present in the patient with double elevator palsy. In these cases, when the patient is made to fix with the affected eye, ptosis partly recovers. True ptosis, when present, is usually complex type and is associated with Marcus jaw winging phenomena. Amblyopia may be present if there is constant elevation of the affected eye and associated ptosis and asymetropia. Now, this is like this patient I had shown some time back. He came to us with some other complaint, asking he had ptosis of birth.
മുകളിലോട്ട് താഴെ മുകളിൽ മുകളിലോട്ട്
This
നോക്കി
elevation is restricted on the left eye.
ഇങ്ങോട്ട് നോക്കിക്കേ വലത്തോട്ട് നോക്കേ ഇവിടെ നോക്ക് അത് തന്നെ ഇനി അടുത്തോട്ട് നോക്കിക്കേ മുകളിലോട്ട് 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 നോക്ക് വെച്ചാൽ മുകളിലോട്ട് നോക്ക് അങ്ങനെ നോക്കിക്കോ ഇനി താഴെ നോക്കിക്കേ ശരി മുകളിലോട്ട് നോക്കിക്കേ ഇനി വലത്തോട്ട് നോക്കിക്കേ അറ്റം നോക്കി ഇവിടെ അങ്ങനെ ഇനി അടുത്തോട്ട് നോക്കിക്കേ ശരി നോക്കിക്കൊണ്ടിരിക്കേ ഞാൻ പറയുമ്പോൾ വാ തുറന്നേച്ചാ അടച്ചേ വാ തുറക്ക് അടച്ചേ വാ തുറന്നേ അടച്ചേ അടച്ച വാ അടച്ച വെച്ചാ
This patient also got WAV, but he has got a true ptosis and he has got a jaw winging phenomenon. Unlike our patient who had a pseudotosis because of the hypertrophic or low position of the eyeball on the left side. So anyone, these persons with WAV palsy can come to with diplopia later on in life because we are not looking up habitually, So only when they are looking up, then become manifest. So the suppression will not occur that easily unless if we are not using the eye that open. So any questions? Any doubts?
So how to manage the diplopia?
There is nothing to be done. You can if at all you can correct the surgery. There is a surgery for it. I asked him whether to do surgery or not. That the particular surgical procedure name I forgot. What they do is that they take a slip from the both lateral medial rectus and connect it to the superior rectus muscle. That surgical name is there. I don't know. I just forgot it. But yeah.
It's pseudotosis and in the levator dehiscence, both the eyelid is down. So how to find out?
No, that's a point. In pseudotosis, actually not a ptosis. Since eyeball is down, the eyelid appears lower down. In pseudotosis, it will be totally corrected and looking up. So also occurring levated is also totally correct and looking up. But in the case of levated dehiscence, when you look down, the eyelid will be lower compared to the other side. But in pseudotosis, that problem will not occur because on looking down, that problem will be same as other, just like our patient.
Why is it called double elevated deficiency?
Because double means both superior rectus and inferior oblique are affected. It's called monocle. This term.
How come you know that the inferior oblique also is involved, sir?
But elevation is restricted both in the adductor and abductor position. Looking up and out and up and in, both are restricted totally.
So the old picture is different here, ptosis bilateral or unilateral, sir. Not
Here,
so clear in the 2016.
Here, in fact, it's a real. There is some suspicion of a ptosis on the right side, but real ptosis only on the left side. That's also not a true ptosis because eye position is lower down. That is why it appears like a ptosis.
The old picture, the 2006, does it show the ptosis, sir? Because it's not clear in the picture.
Yeah, it is there. This even in 2006, it is there. No, it's clear. It seems bilateral, actually more on the left side.
It's covering up at 2/3 of the eyeball, sir.
Yeah. Upper 1/10 or 2/3.
Why is he developing diplopia later, sir?
Yeah, that's the question I wanted. No, this also I was wondering why should these people develop? No, when we have a problem of congenital, disconjugation, there is a visual suppression occurs. That is because of the images are already separated from the very beginning and the brain data suppressed. But we tend to, in the case of elevator palsy, what happens is we seldom going on looking up. The action of elevation comes only in rare situations, not all the time. Unlike looking down when you constantly you have to look down, like climbing down and reading and things like that. or moving to the other side also, it has been there. But look, the elevation function is in normal life comes only occasionally, unless we are habitually in the habit of looking at. So if you continue to look up in a, suppose it's a particular patient is continue to look up in a person looking up all the time, definitely the visual suppression will occur, diploid will be suppressed. So that will not occur in these patients. So this literature also say they can present with the diplopia, even though the problem is congenital.
So here the lesion is at the nuclear level.
Whatever be the level of not the level of affection, it only means that the visual suppression to occur, for the diploid suppression to occur, that stimulus will be there all the time. When intermittently appear, it will not. I'll show that takes a part showing that thing.
So this is something like a Mobius, like nuclear.
Yeah, something like a Mobius syndrome. Now this is the, can you see the slide? This is from the literature when they combine vertical misalignment, diplopia, abnormal head posture, unable to elevate the affected eye, drooping of the left eye, decreased vision. These are the things which can occur with the double elevated palsy. So this can sometimes be associated with monocular gaze palsy also. That's why they are doing this pulse phenomenon also.
And sir, monocular gaze palsy, how it occurs, the upward, that gaze and the RIML becomes.
Yeah, that's a pathway, there is a for the vertical gaze, the RIML of the fibers goes to the posteriorly, cross through the posterior commission and come and innervate the upward elevating muscles. When that output is, that pathway, one side pathway alone is affected, you get one eye alone can be affected, because from the both sides ultimately you come to reach the one eye.
Yes, sir.
That area is affected, the elevation will be lost only on that side. Just think that just before the entry into the nucleus.
Yes.
Okay. Can we stop?
But in downward it cannot occur, because it is double, like it's bilateral innervation. The gaze.
Yeah, no, downward it cannot occur.
It cannot occur.
Okay, yeah. But what is downward gaze palsy? It has to be bilateral. Unilateral lesion will not produce a downward gaze palsy. Okay, shall we stop? Okay, there is one more question I wanted to ask you. Should we continue with this program or not? Because the organizers voiced a doubt today beginning, that the number of attendees are coming down. So I don't know whether they are not keen interest continuing or not. What about you? What is your opinion?
No, sir, you have to continue.
Continue, sir.
We all are very keen.
Sir, continue,
We
sir.
are keen only.
Continue, sir.
Continue. Okay.
Continue.
Okay.
Sure, sir.
Please continue.
Okay, sure. Then I am only happy to continue.
Yeah, we are happy if you continue.
Okay, thank you. Then we'll continue as usual. Okay.
So without the help of organizers also we can continue, sir, individually with Zoom.
Pardon?
Without the help of organizers also we can continue with via Zoom. If you
Yeah, we can do it. In fact, the Milia people from the Torrent we were doing for Kerala can people, I was doing it before. That I have stopped for the time being. Because this program everyone can attend. No? That's why it's not a platform.
Maybe, sir, need that third, the DM entry is now taking place only, sir. They have not.
Okay.
The exam, finally, sir, going the exam and the years have not joined. So.
Okay, no problem. I have no problem. Even if it's 10 people, I will have only glad to teach. Okay, then, shall we stop? Next week. Okay, thank you all.
Thank you, sir.
Good night.
Thank you. Good night, sir. Thank you.
Thank you.
Good night.
Good night.